Assalamu alaikum. This is an overview of the 30 essential surgical sutures, the must-know surgical sutures. We probably use half of them on a regular basis in our everyday surgical activities. But there will be surgical situations in which a good knowledge of the other half would be useful. We'll go through the 30 sutures one by one. There are 4 interrupted sutures to avert the wound edges, 6 interrupted sutures to invert the wound edges, 5 continuous sutures to avert the edges, and 7 continuous inverting sutures for lumen repair, 2 corners or 3-point junction sutures, and 6 sutures for high tension wounds. Eversion or inversion of the wound edges are related to several factors. We start with the commonest scenario, a single suture loop. The standard way of obtaining wound edges eversion is to have the needle perpendicular to the surface at a distance of an X between the needle inlet and the edge of the wound, down the surface through the dermis and part of the subcutaneous tissue to a depth of another X, cross to the other side by 2 X's and come out perpendicular to the skin surface again at a distance of an X from the edge, and this is going to cause a wound edge eversion. If these dimensions and angles are not followed, you may risk obtaining an inversion rather than an eversion. If you have less tissue in the bottom of the loop than at the top, then this is going to result in inversion rather than eversion when you have an almost circular or a square amount of tissues within the suture loop. Also, if you have a shallow surgical loop, again with less tissues in the bottom than tissues at the top, you would risk having an inversion rather than an eversion. In the scenario of multiple suture loops, like if we are doing a mattress suture or a continuous suture, other factors will come into play. And for example, the horizontal mattress suture, if we end up having the bridges of the thread on the surface parallel to the wound edge, this is going to cause eversion of the wound edges. If the threads on the surface, like if we are closing, for example, a hollow viscous, are crossing the wound edges rather than parallel to the wound edges, then this is going to cause inversion of the wound. You will see examples of this throughout the presentation. So now we start with the first group of sutures, stitches to avert the wound edges. The first of these is the simple interrupted suture, and the standard way to do this is to have the needle perpendicular to the skin surface at a distance of an X from the wound edge, and then puncture it to a depth of X through the subcutaneous tissue, come out from the other side again at a distance of X from the edge, and this is going to produce an eversion of the skin edges. You see here the distance from an X from the edge perpendicular to the surface and out, and the skin edges is now averted. And then the vertical mattress suture, starting with the far near version of the vertical mattress suture. It's needed to avert the skin edges, but also a precise approximation of the wound edges are required close to an anatomical landmark like the nasal ala, or when there is a high tension wound. It's actually formed of 2 sutures connected together, the far and the near loops. The far would, the point of entry would be 8 millimeters from the wound edge, and it involves a depth of 8 millimeters down from the surface of the wound. The near would be 2 millimeters from the wound edge and would only go as far as 2 millimeters inside, only into the dermal layer rather than the subcutaneous tissue. So you start with the far point to the far point on the other side, 8 millimeters away from the edges, and then the near to the near into the dermis, and retrieve the needle and tie the knot, and this is going to cause eversion of the skin and disperse the tension better. One other version of the vertical matrix suture that can again cause eversion of the skin edges is the near to near, far to far vertical matrix. Here we have the two suture loops connected. Start by the near to the near. This is going to give you the small and the shallow loop of suture, and then you go to the far and to the far, which will give you a big and deep. Starting from the near to the near, like in here, will allow more precise approximation of the wound edges beside a special landmark, and then followed by the far to the far, and then the knot will be tied. And now to the horizontal matrix suture, starting with the everting interrupted version of the horizontal matrix suture, in which we end up having two bridges of the suture line on the surface parallel to the wound edge, and this is going to cause eversion. We start 6 millimeters from the wound edge down to the depth of 6 millimeters into the wound, out from the other side 6 millimeters again from the wound edge, and then to another level and do another suture 6 millimeters away from the wound edges on each side, tie the knot, and you will end up with the required configuration to cause eversion. It also is quite useful in holding fragile skin, like in patients who are elderly or have been on chronic steroid therapy for a while. It's also useful as a hemostatic sutures, particularly in wounds in the scalp, for example. One other version of the horizontal matrix suture can also cause skin edges eversion, the continuous version, in which we just repeat the units of the everting horizontal matrix suture, leaving about a bridge of the thread parallel to the wound edge, going from one level to the other, 6 millimeters from the wound edges, out from the other side, and so long as the bridges of the thread are lying parallel on the surface to the wound edge, this is going to cause eversion of the wound edges. We now move to the second group. These are stitches designed to invert the wound edges rather than avert it. This will be required while suturing hollow viscera like stomach, colon, pharynxes, but also on the skin surface if we are working in wounds along skin creases or in skin folds where you don't want the wound edges to avert. There will be 6 types of sutures that can give wound edges inversion. Starting with a horizontal matrix suture, again modified this time so that you end up having the bridges of the sutures on the surface crossing the wound edge rather than parallel to the wound edge, and this is going to produce inversion rather than eversion. So if you in this version of the horizontal matrix sutures, you can see the bridges are perpendicular to the wound edge. This is by passing the needle parallel to the wound edge rather than across it, cross to the other side, and then again pass the needle parallel to the wound edge, retrieve it 6 millimeters from the edge, and now tie the knot, and you have two bridges lying perpendicular to the wound edge. This would be useful if we are repairing a puncture in the viscera, a short segment, for example, or wounds in along skin creases or skin folds. A continuous version of this modified horizontal matrix suture, in which the unit of the reversed horizontal matrix suture is repeated along a segment rather than just once. Again, we pass the needle parallel to the wound edge on one side, cross to the other side, and do the same. And this is going to result in a suture line bridge perpendicular to the wound edge, and this is going to result in inversion. And then the interrupted cruciate stitch, which have some resemblance to the horizontal matrix suture. We start 6 millimeters from the edge, cross to the other side, and now go back to the initial side again, 6 millimeters from the edges, and cross to the other side. And now when you tie the suture line, it will be like a cross configuration rather than parallel bridges of suture line. And this would provide a stronger type of closure that can actually disperse tension a little bit better. It also prevents eversion of the wound and induce some degree of inversion. So far we've been through three different modifications of the horizontal matrix suture that can produce inversion of the wound edges. The fourth way of inverting wound edges is a modification of the vertical matrix suture. Rather than having a far, near type of vertical matrix, or even a near, far vertical matrix, you have here a far, near, far arrangement, and this is meant at least to prevent eversion of the wound edges and sometimes cause a little bit of inversion of the wound edge as well. And of course it provides a greater mechanical strength to the wound edge. So you start from the far on the initial side, go to the near on the opposite side, then again to the near on the initial side, and end up with the far on the opposite side and tie the knot. You will have two exposed loops of the suture strand. One is smaller and deeper, and the other is larger and more superficial, and this is going to invert or at least prevent the wound from eversion if you are working in a skin crease or a skin fold, for example. So this is how you start from the far end on the initial side to the near end on the opposite side, then go back to the near end on the initial side, and end at the far end of the opposite side. So you have a far, near, far configuration, and now you tighten the suture and you can see the two loops. One of them is deeper and will be smaller loop, and the larger and more superficial will be formed when you are tying the knot, and the skin edges would invert and you wouldn't be able to see the smaller and the deeper loop of the suture strand anymore after tightening the suture. Another interrupted inverting suture is the Lampert suture, which is basically a modification of a vertical matrix suture in far to near, near to far configuration. You start from the far point on one side to the near point on the same side, cross the wound edge from the near point to the far point, and then tie the suture. By this you would have two loops of the sutures. One of them is between the near to the near on the surface, and the other between the far and the far again to the surface. And because the bridges of the thread are crossing the wound edge, it would invert the wound edges. Notice that while passing the far to the far to the near, the needle is not passed through the mucosa, just passed into the submucosa to avoid any perforation of the mucosa. It is useful in closing up of short segments in the pharynx or in any hollow viscera. And then Holstead inverting suture. Holstead has suggested using two parallel vertical matrix sutures, like the Lampert sutures, connected together like a horizontal matrix. So it's a hybrid between vertical matrix and horizontal matrix. This is a Lampert suture, far to near, and then near to far. And now rather than tying the knot here to end up with a Lampert, we don't tie it. We're just going to continue and do another Lampert in the same way, far to near, and then near to far, and then we can tie the knot. So you have two parallel Lampert sutures connected together, much like a horizontal matrix suture. And now to another group of sutures developed for other functions. Stitches developed to suture a corner or suture a 3-point or more junctions. The problem with suturing a corner or 3 points is that the blood supply to the angled pieces of skin or flaps would already be compromised. We would want to avoid compromising it any further with any stitches across the skin. All the sutures in the angled piece of skin or the corner would be subcuticular to avoid compromising the blood supply to the tip, and should be taken about 4 millimeters from the tip to allow a better circulation to the tip. This is basically a half-buried horizontal matrix suture. Half of the horizontal matrix suture would be on the surface and the other half would be buried underneath the tip of the angled piece of skin or flap. So we start from the wider side, having puncturing the skin perpendicularly, and then come out, and on the angled side, 4 millimeters from the tip, you go subcuticularly, just in the dermis, come out from the other side without puncturing the surface of the skin, return back to the wider side, and now you have a horizontal matrix suture. Half of it is buried under the tip of the corner stitch. And this will be useful in situations like an M-plasty, a Z-plasty, a V to Y plasty, or in wounds having shapes like an X or an L or an T, all with angles. The other suture is a 3-point junction suture. It can be also used for more than 3 points. It's basically, again, a subcuticular type of suture in the deep dermis without puncturing the surface of the skin, 4 millimeters from the tip of all the angles. So you start on one side and pass to the other, second or the third, all horizontal bites in the dermis under the surface of the skin without puncturing it, all 4 millimeters from the tip of the skin flaps, and then you tie the knot in two perpendicular directions, and this will give a precise suturing of the 3-point without compromising the circulation. Subcuticular horizontal bites and the deep dermis in one flap after the other, and finally through the last flap, and then once the needle is retrieved, you can tie the knot, and because there are multiple directions here, you tie it into different directions. We move now to continuous sutures, starting with continuous sutures that can invert the wound edges, like the ones that we use for eversion of the skin, 4 of them. And then we move to another group of continuous sutures developed to invert the wound edges, like the one we used in hollow viscera or pharyngeal repair, for example. All of the continuous sutures would share a certain pattern. This pattern can be divided into these 4 elements. It starts with an anchoring stitch, the very first stitch to be inserted into the wound, and this would be placed at the wound apex on one side of the wound, and this anchoring stitch would be tied to provide some stability to the suture line, followed by repetitive units of the continuous pattern. The continuous pattern can sometimes be a vertical matrix pattern with 4 punctures at each level, or it can be a horizontal matrix configuration with 2 punctures at each level. The direction in which the needle would cross the wound, either on top of the surface or underneath the surface, would also vary to produce different uh, functions like eversion or inversion. And then the final stitch at the apex, at the other apex of the wound, in which sometimes you would need to reverse the needle direction and work backwards so that to have a secure loop of suture at the apex, and then knotting that final stitch. And because you have only one thread here, you may need to have special knots to provide stability to the suture line. The Aberdeen knot is one way of knotting a single thread suture by forming a loop at the final end of the suture line, and through that loop you pull another piece of the suture line to form another loop, and then keep doing this, pull a loop through another loop until you have a secure knot at the end. So you start with the final end of the suture, form a loop, and through that loop you pull a piece of the suture, form another loop, and then you keep doing the same. Pull a piece of the suture through the newly formed loop, and this is going to form another loop until the very last bit. You pass the needle through the last loop, pull out, and then you have a fairly secure knot with several loops pulled through each other. So this is one way of finalizing a continuous suture line. After having the last stitch, you take a loop of the suture line, pull another loop through it, do the same again. From the newly formed loop, you pull another loop and go on, do this maybe 6 or 7 times until you have a secure knot. Then pass the needle back through the last loop and then bury the knot under the skin edges by having a suture at the apex and cut flush with the skin, and this is going to bury the knot. The obvious advantages of having a continuous suture rather than several interrupted sutures is that you consume less time and also consume less suture material, and you leave around a smaller amount of the suture material in the wound itself. The disadvantage is that if a part of the continuous suture line is compromised, then you risk losing all of the line of the suture. And also, if there is an infection in one part of the wound, it can spread across the whole of the wound along the path of the suture line. In its simplest form, the simple continuous pattern starts with an anchoring suture at the top, followed by repetitive units moving from one level to the other. And these Does not take time, of course. It's not very precise in opposing the edges. That's why it is mainly used in the subcutaneous tissues or in non-exposed skin. But the pattern is the same: anchoring stitch at the beginning, repetitive units moving from one level to the other, and then a final stitch at the end. And if you keep a loop on one side, you can tie it with the other single loop on the other. One way of providing extra security to the suture line is to use the lock stitch or the interlocking stitch or the blanket suture. You start again with an anchoring stitch at the top and move to the second level, and now retrieve the needle through the loop of the thread, and this is going to produce the locking suture line that provides some stability to the suture line. Keep pulling the needle through the loop of the thread and keep doing this until the final stitch. You consume more amount of suture doing this, and it's also more difficult to remove. That's the final stitch now, and you leave a loop on one side and tie that loop to the single thread on the other to finalize the suture line. The subcuticular or the intradermal stitch start with an anchoring stitch with a bite in the deeper part of the wound in the subcutaneous tissue, and retrieve the needle through the apex of the wound at the junction of the epidermis with the dermis. That's how we start the subcuticular stitch, at the apex. And then the repetitive units of horizontal bites at the junction of the dermis with the epidermis. All the bites would be horizontal, crosses the wound at almost 90 degrees until the very end of the suture line, and then a finalizing suture again into the subcutaneous tissue in here to provide stability to the suture line, followed by the Aberdeen knot, and then you retrieve the needle through the last loop, get it out, pass it through the apex of the wound or anywhere beyond the apex to bury the knot, and then cut the suture flush with the surface. It's the one you used if cosmetic results are essential, and also if there is any doubts about developing keloids. And if you use an absorbable filament like a monocrel 4O or 5O, you don't need to worry about removing of the sutures. And of course, a good closure of the subcutaneous tissue to provide a good support and a tension-free wound and obliterate all dead spaces are required before all these continuous sutures, particularly the intradermal subcuticular type of a suture. An everting continuous horizontal matrix suture can be used in long tension wounds, or if the wound edges are a bit oozing, like in the scalp wounds. It starts again with an anchoring suture, followed by repetitive units of a horizontal matrix suture, crossing the wound under the surface and leaving bridges of the suture lines parallel to the wound edges to induce some eversion of the wound edges. And now to another group of sutures, the inverting continuous sutures used for the repair of a lumen. If there is a puncture in the lumen of a hollow viscous or a very short segment, interrupted sutures can be used, like a horizontal matrice or a Lampert or a Holstead. But if it's a long segment, the repair would require a continuous suture and then other sutures like Cushing, Cornell, Lampert continuous, or other types of continuous inverting sutures would be needed. These are 6 different types of continuous inverting sutures. The Cushing and the Cornell are almost identical, except that the Cushing engages the submucosa and avoids penetration into the mucosal layer, while the Cornell layer actually penetrates into the lumen of the viscera. Then the Lampert version of inverting continuous suture and can be used either in the far near near far or the near far far near types of it. The Utrecht suture, the Schmiden extramucosal suture, the Parker Kerr, which is a combination of a Cushing and Lampert, and the first string suture. We'll go through them one by one. The Cushing and the Cornell types of sutures are basically horizontal matrix sutures modified in a way to produce inversion of the skin edge for a continuous suture by having the thread bridges on the surface of the serosa, for example, the outer surface of the viscera, perpendicular to the wound edge. So again, you start with an anchoring stitch, then continue with a bite parallel to the wound edge, cross the wound edge on the surface, so you have a thread of the suture on the surface, another bite parallel to the wound edge, and then across the wound edges on the surface, and this is going to produce a continuous inversion of the wound edge. This forms the basis for the Cushing and the Cornell type of sutures. The anchoring stitch starts just below the apex of the wound and go up above the apex of the wound. That's a horizontal matrix suture, and you tie the first knot. And then repetitive units of modified horizontal matrix suture, bites parallel to the wound edge and bridges of the thread across the wound edge until you reach the final suture. Reverse the needle, and now you have again another horizontal matrix suture in the different direction to the repetitive units, and you end the suture line with an Aberdeen knot. So this is the Cushing and the Cornell sutures. The only difference is that the Cushing suture avoids passing through the mucosal layer, while the Cornell suture passes through the lumen of the viscera by penetration of the mucosa. And then to the Utrecht inverting suture, which has a trapezoid configuration, starting with the anchoring suture just below the level of the apex, from near to far, from far to near, and this is the anchoring first stitch, and then repeat the same units, far to near and far to near on the other side. So you have a trapezoid shape, far to near, cross to the other side, and far to near again, and then move to the next level. This would be the last suture, and you leave a loop on one side and tie the knot with the loop. So basically it's a horizontal matrix suture modification, but with a trapezoid configuration rather than a rectangular configuration, and the bridges of the thread are crossing the wound edges so that they invert the wound edges, and also because of the trapezoid shape they disperse the tension in a better and effective way. The Schmiden continuous inverting sutures take the pattern of near to far at each level. So you go from a near point to a far point at one level, and then near to far at the next level, not the same level. and you progress between levels like this, near to far, on this level, cross and have a near to far on another level, and go on all extra mucosally without puncturing the mucosa, and you would have the threads perpendicular to the wound edge, and this is going to cause inversion. And at the very end, you come close to the apex of the wound, near to far at a different level again, and then the Aberdeen knot. So it's a hybrid between a vertical matrix and horizontal matrix, but it takes the form of near to far at one level and then near to far at another level. And then the Lambert inverting continuous suture, consisting of repeated units of the Lambert inverting suture. You start again with an anchoring stitch at the top, followed by the usual Lambert, far to near, and then near to far, and then you move to the next level, again far to near, cross the wound edge to the near to far, and then you have strands of the thread crossing the wound edges. The near to near would be perpendicular, and the far to the far on the next level would be diagonal, but both would be crossing the wound edge and invert the wound. Remember, we'll be working on the surface of the hollow viscera, like the serosa or the buccopharyngeal fascia. So we'd invert the wound edges into the lumen, and that's the final suture for the Lambert, again with an Aberdeen knot. Another version of the Lambert, this time near to far, far to near continuous suture. So you go from near to far, and then from far to near, and go to the next level, near to far, far to near, then move to another level, near to far, and then far to near on the same level, then go to the other level, near to far, far to near, and continue like this. Again, you would have the perpendicular strands between the far and the far, and the diagonal strands between the near and the near. And they will produce the same effect of inverting the wound edges. A Parker-Kerr suture pattern is a combination of the Cushing and the Lambert. You start the first layer of the repair with a Cushing suture on top of a hemostat or a clamp. But you don't tighten the suture until you withdraw the whole of the hemostat, and then tighten the Cushing suture. That's the first layer, followed by a second layer with the Lambert type of inverting suture, and this will provide extra security, and you use this while closing the hollow viscera stumps, the last bit of the hollow viscera. You combine a Cushing and a Lambert to produce a Parker-Kerr suture pattern. Another inverting continuous suture is the purse string suture, a circular suture line formed by successive bites parallel to a circular wound edge, like the stump of a hollow viscus. By tightening the suture line, the wound edges would approximate and close up the circular defect. It will also invert the wound edges and cause disappearance of the stump inside the hollow viscus. The purse string suture can also be used to secure catheters and drains to the skin. We move to another group of sutures, sutures developed to handle high tension wounds. These are sutures that can spread the tension better along the wound edges. They are designed to suture structures like muscles or tendons or cartilage if we're doing pinaplasty, for example. They can handle well fragile skin in the elderly or if the patient is on uh, long-term steroids, for example. They help in securing heavy flaps like musculocutaneous flaps or a prosthesis in situ. We'll go through these 8 sutures designed to help in suturing high tension wound. The standard horizontal matrix suture can disperse tension, but the addition of the pulley modification can disperse the tension even better. Now, starting with the standard horizontal matrix suture here with 2 punctures on each side of the wound edge. Now, rather than tying the knot here, we just introduce the pulley modification. You pull the needle through a loop of the suture, and this is going to produce the pulley modification, which disperses the tension much better with a cruciate configuration. And you can see that the wound's edges are approximated even when there is no tension at all at the wound edges without tying the final knot. So that's a simple modification to the horizontal matrix standard configuration just by pulling the needle through a loop of the suture parallel to the wound edge. You produce this effective way of dispersing the tension in high tension wounds. And you would notice here that the wounds are kept in good opposition even without tying the final knot. I dropped the needle and the wound is still in good opposition. The cruciate or the figure of 8 suture is a modification of the horizontal matrix suture. You start from one side of the wound, cross to the other side, then return back to the original side, cross again, and this will bring about an X-shaped configuration that disperses the tension effectively. In the trapezoid suture, rather than having a rectangle or a square horizontal matrix, you have a trapezoid horizontal matrix with far to near on the opposite side and then near to far. Now you have a trapezoid suture that disperses tension better than a square or a rectangle type of horizontal matrix suture. And then the Smith-Jones vertical matrix suture, this time with the pulley modification. You have the standard configuration of the vertical matrix. You go from far on one side to the near on the opposite side, and then from the near on the original side to the far on the opposite side. And you pass the needle through the loop between the near and the near, and this will give the pulley effect to the suture line, and this can disperse the tension much better way. Just this very simple modification adding the pulley effect to the suture line. And then the irregular suture, which disperses tension on multi-levels and multi-directions. Some of the points of entry would be opposing directly, some of them would not. Some of the needle directions would be vertical, some of them would be horizontal, and some would be oblique. And the net effect would be dispersion of the tension in multi-levels and multi-directions. It's effective in holding up fascia or muscles to bring about some dispersion of the tension in the wound. And finally, the interlocking loop suture, used for the repair of cut tendons. It's basically two mirror-shaped horizontal matrix sutures, starting from the cut ends of the tendon. You pass from the near side to the deeper into the tendon, and then go through the tendon tissues to the far side, come out from the cut end of the tendon, and that's one horizontal matrix suture. Then you go to the other end of the tendon, the other cut end, and again from the cut end to the outside, this time on the near side, and then crosses through the tissues of the tendon to the far side, and then bring the needle out and pass it through the cut end of the tendon at the far side. These are two horizontal matrix sutures, mirror shaped. Pull the threads and you get a good opposition. And if you use it for maximizing the tension dispersion and use of non-absorbable sutures. By this we come to the end of this overview of the 30 essential surgical sutures. Assalamu alaikum.